Hi, everyone. Today we are gathered to discuss a very relevant and important and challenging topic, that is the role of role of harm reduction in addressing tobacco use disparities. The hope really from this conversation is to gain a deeper understanding on the barriers coming in the way of achieving equitable health outcomes for those who are affected by smoking. So joining me today in this conversation are experts Kevin McGurr, who has a background in program and research in substance use and mental health. And he's a clinical professor at the Department of Community Health Systems, the University of California, San Francisco. We have Patricia Theo. Patricia has a nursing background and is an associate professor of behavioral and social sciences at the Center for Alcohol and Addiction Studies at Brown University's School of Public Health. And Mark Sliss. Mark has a background in marine biology, but today he'll be sharing his insights from his experience as a vape shop owner and as someone who has previously smoked. Before moving further, one housekeeping detail is that my colleagues Chelsea Boyd and Addison Garner will be monitoring the chat window. We also have a Q&A box at the bottom of the screen where we encourage you to leave your questions. And at the end of the discussion, we'll be addressing those questions. Now, because it is such an interesting topic, there is a chance that we run out of time. So in that case, I'll leave my email in the chat so I can get back to you with the answers from the panelists. I want to set context for our chat today. So for that, I'd like to start with the definition of health equity. So the Centers for Disease Control and Prevention defines health equity as a state where people have a fair and just opportunity to be as healthy as possible. And achieving health equity requires valuing every person and their health fairly, addressing problems with systems in our environment, unfair practices, and unjust conditions that can weaken the health of specific population groups. Working with different populations in specific and sensitive ways to address health conditions that affect them is another requirement for health equity. So with regards to smoking, smoking rates have drastically come down to 12.5% in our country with about 31 million adult smokers. But in certain subpopulations, we have not seen smoking rates drop at the same pace. CDC in their report say that the smoking, tobacco-related disparities, secondhand smoke exposure, smoking-related health problems, and access to treatment are all disproportionately distributed based on where people live, the type and amount of employment and health insurance they have, social factors and demographic factors like race, ethnicity, age, sexual orientation, disability status, level of education, income, behavioral health conditions are all important factors for this disproportionate distribution. Another example is that smoking rates among people living with HIV are 3 to 4 times higher than the national smoking rate. So with all those facts in front of us, I'd like to start my first question and probably ask Patricia to start with, to open. What is the biggest challenge to reduce or eliminate smoking at the moment in subpopulations where smoking rates persist at a much higher rate?
Thank you, Pratika. Thank you so much for inviting me to speak with the group today. So it's a pleasure to be here. And I'd just like to say that I'm a researcher, but I'm also a clinician that provides primary care to people living with HIV. So I'm still very much involved clinically and see patients on a weekly basis. So I feel like I have an inside track to what those significant challenges are among patients who smoke. As you mentioned, smoking rates have declined considerably in the United States in general, but among those subpopulations, we have much higher rates of smoking. And in people with HIV, we generally see about 40 to 60% in most studies that smoke. So they do have much higher rates of smoking, and they also have more difficulty quitting and staying quit. We conducted a study about 4 to 5 years ago, asking former and current smokers what their most significant barriers were. What were their challenges to quitting smoking? And we learned quite a bit. What we learned is they have very high levels of nicotine dependence and smoke heavily, and that makes it difficult for them to quit. They also have many smokers in their social networks. So their friends, their families, their social group, they're surrounded by smokers, which we know is a barrier, making it more difficult to quit. They also have significant comorbid anxiety and depressive disorders. So just among this general population of people with HIV, we see significant psychiatric comorbidity as well. And we know that's a negative predictor for successful quitting. They also suffer loneliness, isolation, stigma related to HIV. Even in 2022, we still see significant stigma and isolation. And then finally, something that really surprised us was that a good majority of people had ambivalence toward quitting. They felt like they had given up so much in their life and they didn't want to give up smoking. So that was something they were continuing to engage in and weren't really interested in smoking cessation therapies. So as a result, people with HIVs have serious health inequities. They're 2 times more likely to have a heart attack compared to the general population, and they're 5 times more likely to have cancer, a cancer diagnosis. And one study that was published about 4 years ago actually reported, based on a very large meta-analysis, that people with HIV lose more years to smoking than they do to HIV infection itself. So this is very concerning.
Those are such, such interesting and relevant facts. Thanks for sharing, Patricia, because one thing that stood out to me was when you talked about comorbidities, and by comorbidities, we mean the coexistence of other health conditions,
Yes.
Right? And that is something we don't really hear much when we talk about adult smokers. And we're there, and with all the stigma that has built up over the years, with smoking, smokers are seen as smokers and everything else kind of fades off. So that was a really great point. In fact, at this point, I'd like to ask Mark a follow-up question. Can you share from your experience, both as someone who has smoked before and as now as a vape shop owner, you interface with this population. So if you can shed some more light on this.
What Patricia said is exactly correct. It's exactly what I see. I deal directly with people who smoke and help them face to face on a daily basis. I see most of my clients once a week, once every 2 weeks, and all those things are true. In addition to that, I would add there's an element of distrust of authority, of health authorities. Well, I would just say I agree with all of that. I see it every day, every single day.
Thank you, Mark. Kevin, would you like to add something here?
Sure, I would echo just about everything that Patricia had indicated. What I would add, and just to give people a little bit of insight as to the recent work that I've been doing, I've been leading a research effort with people who are public health users in behavioral health systems in Providence, Rhode Island, New York, and San Francisco, where we enrolled over 300 individuals. And essentially, these individuals are near or below the poverty level. They're individuals with severe mental health issues and or substance use issues. And when we think about it or attempt to think about it from their perspective, the question might arise is, why the hell should they care about smoking when they've got an incredible amount of adversity, stressors, near homelessness, and challenges that are distracting them from being motivated to change their smoking? We know, based on research prior to any work that I have done, that smoking, in addition to having neurobiological benefits for individuals in this population, it's habituated behavior in a way that this practice has become a long-term friend. Most of our individuals in our research started smoking, at incredibly young ages. It still astounds me when people tell us they started smoking when they were 10 years old. and they're now 50 years old. So they've had a long-term relationship with this behavior. So their motivation is going to be very, very frail. And maybe a little bit later, when we talk about what needs to happen, I'll be happy to kind of, provide some opinion and perspective with what I think needs to happen with this population.
Thank you, Kevin. Yeah, we know that from data, we know that most people who smoke, they want to quit, but only 5 to 7% are really able to. And even with those who are able to quit, the relapse rates are quite high.
Yep.
So currently the most common methods prescribed are to reduce harm from smoking or to quit. And to that effect, we have quit lines and we have nicotine replacement therapies and we have counseling. But how effective are these in the subpopulations that Kevin, you spoke about? And so would you like to share something on that? And then maybe we can follow up with Patricia and Mark.
Yeah, I don't want to disparage, the older conventional methods. I do believe that they do work for many people. I also, like Mark, I am a former smoker. I didn't use anything to change, but my change pattern, took many years before I finally quit for good. And again, to my knowledge, I don't have a severe mental illness or substance use issue, and I'm quite educated and comfortable. So I have more of a context to help me and motivate me to stay away from smoking. And what they have, and prior to this presentation today, I look to see, again, what's happening in my own backyard, around people getting help around this. So they get 4 sessions, and at my university, which also does some smoking cessation, it's also anti-vaping in addition to, anti-smoking. So already a major barrier is put up for individuals who might be interested in using alternative, newer, novel nicotine products, which I think, of course, is a travesty. What we learned from this population is that they benefit from longer term engagement. So in our research, we gave people 6 months of weekly counseling. We gave them choice of what products they want to use, including the conventional products, but also vaping products, as well as the conventional medications. Most people did choose the vaping products. Most people were satisfied with those products. However, we have not achieved a significant amount of abstinence. We know that the research has already told us there's going to be oftentimes a protracted dual use pattern for many individuals because, as I've indicated earlier, this habit has a decades old baked in for individuals in this population. So to expect that people are going to stop smoking after 4 weeks, or frankly, and I might be a little controversial here, stop smoking because they have been introduced to vaping products, I don't think we should expect that that's going to happen as quickly as we might like it to happen.
That is a good point, Kevin. In fact, just to give context, you are based out of San Francisco, and it's interesting that San Francisco and California have been at the forefront of harm reduction in other forms, and not so much in tobacco. So that's an interesting juxtaposition. Patricia, would you like to follow up?
Sure. Yeah, you asked about, the FDA approved therapies. And, I think we know that they are very effective therapies when they're used as recommended for most people. But I think among some of these subpopulations, and I can speak specifically to people with HIV, there's very often poor adherence to these therapies for multiple reasons. There may be a lack of interest. We're dealing with polypharmacy, which means, they're already taking many medications. They're taking their medications, antiretrovirals for HIV. They may be taking medications for depressive disorders or hypertension, diabetes. They have such a complex medical regimen that they're very often unwilling to add more medications to those regimens. So that may be an issue. They're also very concerned about interactions, even though we reassure them Many of them have been living with HIV for a very long time, and they are on successful antiretroviral therapy and their virus is suppressed. So they're very fearful of making any changes or adding something that could potentially cause their antiretroviral therapy to no longer be effective. So that's a concern. And then one thing that comes up often with this population of patients too is they have treatment fatigue. They've been in treatment for so many years, seeing doctors, doing testing, taking medication. So to try and convince them to do one more thing to improve their health, it can be very difficult. So I think there again, we go back to those challenges. And I just want to echo something that Kevin said, because it reminded me. He said, for many people, the cigarette is a friend. And that's something we heard over and over again in our qualitative interviews. There's so much isolation, so much loneliness, and they did look forward to having that cigarette. And it was like a friend to them. They used that exact wording. And so there you're trying to break a bond where they've already established a relationship and a coping mechanism. So those things make it difficult for these traditional therapies sometimes to be effective.
Yes, that is definitely very insightful. And I remember, more than 2 decades ago, I hope this doesn't age me, but, more than 2 decades ago, I used to work as a mental health professional. And smoking was not even the last thing that mental health professionals were trained to address, because there were so many other coexisting issues that took the precedence. And also, from what Kevin and you shared, it seems like trust, and Mark shared it earlier too, like trust seems to be a key factor. And then also the fact that there may be people who smoke who don't really see it as a medical issue to seek medical help for. So I would actually like Mark to weigh in on this. Mark, based on who you interact with, your clients, your customers, what do you see in your experience?
Well, I want to take it a little bit further. What Patricia said about smoking being your friend. The people I talk to in my personal experience is that we all like everything about smoking, except that it's expensive, it stinks, and it kills you. Which is why vaping is so effective. Here's my friend. We give them the same thing that they get from smoking. We give people who want to quit a friend, something that takes the place of smoking, and in fact does a better job of it in some areas, like flavor and scent. Tastes great, smells great, gives me what I need, takes care of me. I see people, they personalize these, they name them. She's spot on. Smoking is our friend. I think Kevin would agree, as an ex-smoker. There's a lot of positives, or we perceive a lot of positives from smoking. It becomes very important and ingrained in your life.
But
Smoking often determines where you work, where you live, who you date, who you marry. It becomes an intimate part of your life, whether you like it or not.
I'm curious about how do your interactions happen? And you shared, I've been in forums where you have previously shared on how that transition happens. And do people have the information they need to know that there is a risk continuum? And maybe, Mark, you could start, and then I would love for Patricia and Kevin to talk about this risk continuum a little bit as well.
Okay, well, I think a short description of what happens when somebody comes into my shop to quit smoking or any tobacco use. Most of them have tried most of the other conventional methods and failed, many of them for decades. Average age of my clientele is north of 40 these days. They come in, I introduce myself, I tell them a little bit about what's going to happen, how I do this. And the first thing we do is we sit down face to face and I learn what I can about them personally, their lives, their lifestyles, their jobs, their smoking habit. And at the same time, I introduce them to vaping and the devices, how they work, how they facilitate smoking cessation. Um, so we spend time getting to know each other. It's a personal relationship. I don't call them customers, they're clients. I don't sell a product, I offer a service. I explain my history with smoking and trying to quit for 30 years. Then the two of us, once I've empowered them with a little bit of knowledge, and I've learned what I need to learn about them personally, we craft a solution tailored to fit all of their needs, their lifestyle, employment, what happens in their daily lives, their smoking habits. We tailor a solution together that fits them individually. And I think that's really important. And I think that's why we're so successful. And basically, as somebody who smoked for 41 years during modern tobacco control, what I try to do personally is the opposite of everything that was done to me by tobacco control. I make it personal, I make it tailored to fit the individual. And it seems to work quite well.
Yes, thank you, Mark. In fact, Mark and I were having a discussion sometime earlier about, Mark, based on where you live, and like I pointed earlier, that, there is a disproportionate amount of a number of smokers based on where they live, and also what access do they have to the treatments that we were earlier talking about. So Mark, based on where you are, if you can share, if you can share a little bit about that, and then what access do adult smokers have in your region to outside of your vape shop? What other access do they have to reduce their or to eliminate smoking?
Locally, essentially nothing. We have a Western Upper Peninsula Health District that serves approximately a quarter of my state, the northwestern corner where I live. And if you go to their website, they have nothing on smoking cessation at all. They have one person who's in charge of smoking cessation. And after a phone call to the health department, I was told you can come in and they have some pamphlets on a desk for you. And that's smoking cessation for a quarter of my state. So essentially nothing.
That's
nothing to actually help people.
Yes, because I think Patricia and I were talking about it earlier as well, and it seemed like it's very different in Rhode Island. So, and that just goes to say that how it's not an even playing field for everybody.
Yeah, it really isn't at all. I mean, in Rhode Island, we have a very active Department of Health with regard to smoking cessation. We have a quit line that is in place. Patients that call the quit line can get 5 telephone-based counseling sessions over the course of their quit attempt. They can also get access to combination nicotine replacement therapy. So that can be patch and lozenge or patch and gum. So they have a fairly comprehensive program, and most insurances will cover the oral medications, probably, I think, for 2 quit attempts per year. So those options are available to patients, and they're good options. It's just that they don't always work for everyone. You know, we know that the best option for patients who smoke is to quit completely using combustible cigarettes. So quitting smoking is the healthiest thing you can do. And I tell this to my patients, it's the most important thing you can do to improve your health is quit smoking. And we have good research evidence to back that up. But it's not the option that everyone desires. And I think Mark made a good point saying that he enters into a collaborative process, talking with his clients like I do with my patients about what are their goals. And for everyone, quitting is not the goal, quitting combustible cigarettes. So I think we need to work closely with our patients or our clients to determine what is their goal for improving their health with regard to cigarette smoking. And we may be able to reach a point where they're willing to give up combustibles, but still maintain that dependence on nicotine. And that's where I think tobacco harm reduction has a really important role. You know, it's surprising to me that as a healthcare professional who's worked in a clinic for opioid dependent individuals where we encouraged patients to use methadone or to use buprenorphine, which are both harm reduction. Working in HIV, we prescribe PrEP, which is pre-exposure prophylaxis, so people don't become infected with HIV when they engage in high-risk sexual behaviors. You know, we can look at other areas for harm reduction and be completely comfortable with those. But when we start talking about tobacco, it's very polarizing. You know, a lot of people are totally against tobacco harm reduction. But I think we need to be more willing to think about where patients are at or clients are at and to work with them collaboratively to help them achieve the best health outcomes for them. I don't think it's a one size fits all.
That's a great point. It's not one size fits all. So if it's not one size fits all, then where do less harmful or safer nicotine products fall in? You know, you shared a little bit about how your patients, you see the lack of trust, not being open to another medical treatment. So what do you see in your experience, and also based on your research? And we'll start with you, and then maybe we'll go to Kevin after this.
Okay. Yeah, so, you know, the FDA has talked about the continuum of risk, tobacco continuum of risk, which I think is important. You know, that we have on one side of the continuum, the most harmful products, which are the combustible cigarettes. And then, of course, we have no use at all, which is the best for your health. But for those people who are using combustible cigarettes, moving towards something lower on the continuum of risk, such as a nicotine replacement or an electronic cigarette, one of those options has lower risk to your health, decreased risk. And I think it's important to consider that whole continuum of risk when we're working with people who smoke. And the research evidence supports this. You know, we have very good research that has come out of Roswell Park with Dr. Gonowitz, who has looked at tobacco toxicants and measured those in people who continue to smoke combustibles, people who become dual users, and people who make a complete switch to an electronic cigarette. And these are very large studies. One of the studies that's been published had over 5,000 participants, and they showed very definitively that tobacco toxicants are significantly reduced when people make a switch from a combustible cigarette to an electronic cigarette. So I think we have good emerging evidence to show that these are less harmful products for people to use when they're unwilling or unable to quit smoking.
Thank you, Patricia. But that brings up a question for me is, and something I've heard from study participants in the past is, do you have to completely switch to a different product to see the benefits? Or, you know, what is your opinion on dual use, and also based on research? And I'd love to also ask Kevin about the same.
Yeah, I'll just make one point about that, because the studies do look at dual users. So there is not as much benefit. And in fact, there's very little benefit. But we're also learning, as Kevin mentioned earlier, that some people just take a longer time to make it to exclusive e-cigarette use. So it's not an instant, like an on-off switch where we move from combustible use to solely electronic cigarettes. While some people are able to do that, and in one of my studies, we actually saw 30% of participants make that complete switch by 12 weeks, which is great. That's a significant outcome. But not everyone is able to do that. But we're starting to see some emerging research evidence where people take a little longer to make that switch, but they eventually do quit combustibles. So I think, you know, we're still in the infancy with electronic cigarette research. in this area, but I think we're starting to see some good evidence that people can make a complete switch, which is the healthier option.
So if I'm understanding it correctly, it seems that what you're saying is that you may not see immediate significant benefits in terms of health in dual use, but dual use is a way to off-ramp over time from smoking to a safer or a less harmful nicotine product.
I think the research evidence is telling us that it can be a pathway toward exclusive e-cigarette use. Yeah.
Thank you. Kevin, would you like to share?
Yeah, I certainly don't disagree with anything that has been said by either Patricia or Mark. I mean, what I would add, and I would then, I think, echo, the approach that Mark takes in when someone comes into his vape shop. I think it's incredible how he describes, and I guess he's not even a clinician, but the way his response to working with people is what all clinicians should be doing, by being open, by not demanding that people are going to change, by listening to where they're at, but also, and maybe this is, beyond the vape shop, I think as systems, we have to kind of conceptualize that people's change will be iterative over perhaps a very long period of time. And that by staying engaged and not shaming and blaming people if they don't make significant change, we're going to get a lot more connection and engagement with people over a longer period of time. So I do think that's really where public health systems need to go. They need to standardize where the door is open and that the door can revolve, that you can come back if you're not ready to make a change right now. I would also add, and I know that echoing some of what Patricia was saying earlier, the analogy with other drug use. We don't use the term smoking cessation or quit in my research, again, because my concern is that those words can become barriers to people in the same way that when we have a harm reduction drug or alcohol approach, we don't say quitting, abstinence, or cessation. We allow people to come in to decide their goals. And if their goals right now are just to reduce, we say any positive change that's moving in the right direction, we think that's excellent. We tell people that the safest thing to do is to not use anything, to not smoke, and maybe not even use nicotine, although clearly it's all about what's going to help you move in a direction away from combustible in the immediate or in the long term.
That's a great point. In fact, what really came to mind when you were sharing that, Kevin, was that it's very interesting that we have been able to embrace the organic movement towards, getting to a safer, healthier, less harmful space in other substances.
Yep.
We've done that with alcohol. We've done that with other substances, but it's interesting that we are having a lot of difficulty as a society to embrace that in the tobacco space. And so that was a really good point. And in fact, I'd like to ask Mark a question here, is that where do you see the role of independent retail vape shops in addressing, these disparities through the availability of less harmful nicotine products?
Well, we're losing a bit of the independent vapor industry. It's changing. We've lost a lot in the last 3 years. But in 2018, we had about 15,000 vape shops, probably the majority of them owned and operated by ex-smokers, all 50 states. We had a network that was working quite well. We generate communities organically. You already mentioned the word organic. I don't advertise at all. All of my customers come in, they're usually brought in either word of mouth or they're brought in by another successful client. And they generate their own communities. They bring their friends in, they come in as groups. They create their own groups. In talking with you the other day, I mentioned that 6 years ago, I helped a couple of young Indian fellows to quit when they came over from India to go to the local college. And they've created their own organic community that has existed for the last 6 years. And in fact, after we spoke just yesterday, two of them came in and brought a third fellow, and I helped another one to quit. It happens all on its own. And all we do is empower them. We offer them a superior product. We empower them with education and the knowledge that they need to make it happen for themselves. And I see probably an 80% success rate here. I don't see that anywhere else. It kind of works on its own. Which I find interesting. And we have the vape shop community, but like I said, we also have these sub communities that they've created themselves. Nobody said go out and grab your friends and bring them in. They have a positive experience here and they bring them in. I think that's also important, that people do this on their own terms. The people who walk through my door, they know what they want to do. And that seems to be a great starting point. We just give them the tools.
That's a great point, Mark. You know, that kind of brings to mind about who the other stakeholders are really, you know, typically in the tobacco harm reduction space. And as someone who has background in mental health and then in public health, we see some voices are louder than the others. And so I'd like to ask you all, maybe we'll start with Kevin here, is who are the stakeholders in this discussion and whose voices are we missing, and how can we, you know, facilitate stakeholder collaboration to improve regulation in this space?
Yeah, for me, the primary stakeholder should be the smokers and the consumers of services, whatever those services might be, whether they exist or not. And I think going back to echoing what you were talking about earlier, Pritika, around health equity, to me, you know, this is a social justice issue. You know, when we think about, I mean, tobacco is still the major killer of people with mental health and substance use problems. More people are dying from tobacco than they are from heroin overdose or opiate overdose or alcohol. So that's still the #1 killer. So to turn that around, you know, really is going to require, you know, significant shifts in the way that public health is addressing and embracing, you know, tobacco intervention in general, but also tobacco harm reduction. So hearing the voices of individuals, you know, who are like down there and dirty around this issue, that needs to occur. One small project, as we evolved in our research, we began to make a connection with CASA, the Consumer Alternatives Around Smoking. They're a great organization. They have incredible database of individuals, but we're also helping them kind of focus on individuals in this particular vulnerable population, and they're doing a great job in terms of stepping up to do that. So we're in the process of also making a video of individuals, you know, both in terms of their relationship to tobacco, what it has meant to them, but also the process of change. And I think that's what providers need to also hear. What is it like for me to make a change around my tobacco use?
Thank you, Kevin. Patricia, would you like to follow up on that?
Yeah, and I would probably echo what Kevin said. I agree. I think the missing voice here is the people who smoke. I think we need to do more work to listen to those voices and let them decide what are the options that they want available to them. What is what is the end game for them? What is their goal? You know, we need to really work very collaboratively, like we do in other other healthcare areas. You know, what are their goals? How do they want to achieve optimum health? So I think, yeah, the patients' voices are definitely the ones that are missing.
That's a great point. Mark, would you like to add something here?
Yeah, I think what they both said is 100% correct. People who smoke, they are the stakeholders. People who have successfully quit smoking with vapor products or anything, they are also the stakeholders. They are barred from stakeholder meetings. Literally barred from almost all of them. That's a crime. That's an absolute crime. I get the impression as somebody who smoked and somebody who's quit and working in the independent vapor industry, that the hatred of big tobacco appears to have been transferred to people who use tobacco. A great example, just yesterday, had a medical doctor on Twitter who called a bunch of successful people who successfully quit smoking with vapor products fake harm reduction advocates. Absolutely dismissing people who actually quit smoking successfully. We're not just not part of the conversation, we're barred from the conversation. We're called fakes. Somehow that has to change. I have the distinct impression that today's tobacco control is doing the exact opposite of what it should be doing. And honestly, that's what I base my success on and the people that I've helped. I do the opposite of what was done to me and what I see tobacco control doing today. And I've been very successful. We need a big shift, a big shift. At the end of the day, we're actually, my industry, the independent vapor industry, totally focused on helping people to quit smoking and other deadly forms of tobacco. We're being eliminated while deadly combustible cigarettes are more readily available than milk.
You know, it's interesting that when I think about tobacco, and I often compare it sort of in my mind with what have we done with alcohol? You know, very often when we talk about electronic cigarettes, there's this concern and focus on adolescents and young adult smokers and the potential harms. And of course, none of us want to see teens starting to vape or young adults starting to vape, because we don't want to build another generation of nicotine dependent adults. But I think we need to separate the potential harm that can be done with adolescents and young adults and the potential benefits that can come to long-term adult smokers that are unable or unwilling to quit. I think we need to come to some sort of compromise way of dealing with both. I don't think it needs to be an either or. You know, alcohol is legal in this country, but we found ways to keep it out of the hands of children for the most part. And I think we need to come to the same sort of place with regard to nicotine. I think we need to figure out how can those adults that use nicotine and want to continue to use nicotine, how can we help them to do something that is probably more healthy for them while keeping it out of the hands of children? I think it doesn't need to be necessarily an either or. And it's certainly, like I said before, it's not one size fits all. But I think we need to start thinking in that way. I think we can find a way to do that because we've done it with alcohol.
That is a great example, Patricia. Kevin, I think you were going to say something.
Yeah, I just want to add to what Patricia has said, and we know that vaping has helped an inordinate number of people. Those who are anti-tobacco harm reduction, anti-vaping, I think that they have weaponized children against adults around this issue. And again, I echo what you both have said. No, we don't want to give drugs to kids, but we think about how much harm has happened around nicotine use and teens versus alcohol use and teens. Still, over 3,000 underage drinkers die every year from alcohol use. So the proportion of response to substances is clearly way out of line.
So how would you compare that number to the number of teens who are vaping? I mean, what percentage of?
There's many more kids, many more underage drinkers than there are underage nicotine users. I mean, I don't have the data. I don't know if Mark or Patricia have the data at hand, but my sense is that, you know, alcohol use is much more prevalent and dangerous and harmful alcohol use than nicotine use amongst underage users.
Right.
Yeah, I think smoking rates in young adults and adolescents have actually continued to go down.
Yes.
And, you know, I think we saw when one product came on the market and was very popular with adolescents, we saw a significant spike in vaping, but I think that has leveled off and started to come down actually.
Yes.
And it certainly hasn't led to increased smoking because the smoking rates in this country continue to remain low. I don't have those numbers off the top of my head because it's not the population that I study, but I know that those numbers have continued to go down and have stabilized. So we didn't see, a lot of people feared that the vaping was going to lead to increased smoking in young adults and adolescents, but we haven't seen that come to fruition.
We've seen the opposite, in fact. With the advent of vaping, teen smoking dropped even faster. And currently, regular daily use is in the single digits, teen vaping. And with the majority, I believe 8 of 10 or 9 of 10 reporting first using tobacco. So it appears that the regular teen vapors are actually practicing harm reduction as well. And I think we need to weigh that. We need to look a lot closer at the data and youth use and weigh that what potential risk of a lifetime of nicotine use, vastly safer and healthier nicotine use than combustible cigarettes versus almost certain death for adults who are smoking.
I think
it's a very simple equation, and we seem to be losing sight of that 480,000 Americans a year are dying from smoking, and the majority of them started as children, myself included, at 9 years old.
Yeah,
I see very little negative in teen vaping, very little negative. If most of them were first using deadly products, and most people who smoke start as children.
Mark, great point. I from what I heard, all three of you, I think great points. And yes, youth vaping is of concern, but then it doesn't have to be either or. It is, you know, it takes multiple factors, regulation, enforcement, all of those to come together to make sure that, you know, while we prevent youth use, we're also not forgetting, you know, the 31 million adults who smoke in the country. And so, and from what I hear from you about the stakeholders, it seems, yes, consumers, it seems, you know, are they, and they are the most important stakeholders. And then outside of, you know, the usual voices that we hear, that is public health, we hear advocacy organizations, of course, we hear tobacco control, but outside of that, the other health professionals, you know, the psychologists, the social workers who are interfacing with these subpopulations way more than the voices that we hear are also important stakeholders that we typically forget about. So I think with that being our last question, I'd like to just read a couple of questions that, and some comments even that are here in my Q&A box. And then maybe I'll ask Addison to unmute Chelsea, and if there are any other questions in the chat box, then maybe Chelsea can read those out. But first, there is a comment around, I am interested in learning more about how smoking and vaping are part of mental and physical support for recovery and support. So it seems like, so I think when we were talking about adults who smoke and have coexisting conditions, see smoking as a friend. And so I'll open it to all three panelists, whoever wants to take this. And how is vaping a part of recovery and support?
I will jump in. When I first became aware of vaping products now between 5 and 10 years ago, and I was totally ignorant of them, what I immediately got was that of all the nicotine products, it most mirrored, the habit and the act of smoking. I know that people don't vape in the same way that they smoke, but there is some overlap in terms of like a hand-to-mouth activity. I think, and I know that many people in the population, who suffer from serious mental illness, oftentimes are not employed. They have little going on in their life that gives most of us, meaning and purpose. So to have something to look forward to have something that helps you cope with stress, even though nicotine is a stimulant, many people experience it subjectively as something that helps them calm down, something that helps them manage adversity. So I think, nicotine is an important coping strategy for individuals. What we have done in our research is we also attempt to make people aware of other, non-nicotine coping strategies as well. But we understand that nicotine is going to be a very important and very powerful aid and strategy for individuals.
Thank you, Kevin. I think that also addresses another question that is here is, can you share some real examples of people suffering from mental health and how they are benefiting from vaping? So what you shared, Kevin, also addresses that question to some extent.
I think
No, again, we know, I mean, one thing to keep in mind, people who become, clients and quote patients within mental health systems, they get a lot of drugs. They get a lot of medications. The medications are overwhelmingly sedating. And again, so if you're being constantly sedated, and I've heard this time and time again, from individuals, I don't like being zonked out by the drugs. So it creates this kind of need to counteract some of the sedating effects of the medications. And nicotine and caffeine certainly are two products that will help someone, manage those issues. Nicotine is also being used with, in terms of research around cognitive enhancement, people with dementia, people with schizophrenia, to help around focus and concentration, which people also benefit from a day-to-day basis with nicotine, people who have mental health or substance use issues for that matter.
All of this is discussed in my shop with my clients amongst themselves. All of them recognize everything we've talked about, the comorbidities, the drugs, the additional substance use issues. They're aware of these things. We talk about it all the time. And they're aware of how nicotine helps them, many of them, not all of them, but many of them. They understand how it helps them. It's one of the things that I talk about. I try to get them to understand that, because that helps to craft a better solution for the individual. Not just their lifestyle and their daily habits. And the other thing I wanted to say is you sort of touched on what smoking does for people and what vaping and the devices do. These are companions, and And that's very important. Vaping, it basically mimics most of the aspects of smoking, the hand to mouth, the oral fixation, a cloud that they're used to, the nicotine, a bit of ritual that comes with smoking and vaping. And where it differs is we make it more enjoyable and of course healthy, but you're healthier, less risk. But the goal, and I tell all of my clients on day one, the first time we meet, our goal here is to make this more enjoyable than smoking. And if we can do that, you will quit.
Yeah.
And they do. Almost all of them.
I think another potential perceived benefit by people who smoke is, the social network that comes with that. I mentioned that there's a lot of isolation, a lot of social isolation, a lot of stigma, a lot of loneliness, and anyone living with a chronic illness like HIV or anyone living with serious mental illness. So I think the opportunity that smoking brings, the opportunity to go outside of your building. My study participants have echoed this in research interviews, the opportunity to go outside of your building and stand with a group of 5 or 6 and all have a cigarette together. So when you give someone a patch or a Nicorette gum or something like that, you're not allowing them to continue to engage in that behavior, and they lose that social group. So their social isolation is now increased, which is not good for their overall perspective, for their mental health. When you give them something like a vape, you actually allow them to continue to participate in that social network, but in a different way. But they're still surrounded by other people who are continuing to use nicotine. And so they maintain that social network. And that's, I think, a benefit, at least a perceived benefit in their minds. So.
Very important, very important. And in a vape shop, we create that group in a positive sense. That they come in here and I tell them, welcome to the vape fam. We're 80 million strong. You're part of the family now. And I think that means something to a lot of them. That they still have a sense of identity and belonging to a group, but it's a group that's positive. And I think that helps a lot. And I think that's also why people bring in their friends. They create their own groups. They bring in coworkers, peers, friends, family. I've helped multiple families, 3 generations of that family, to successfully quit smoking and other tobacco use. Because vaping generates that sense of community, and vape shops can do that. Nobody gathers around a patch. Nobody creates a group around a patch.
That's a great point, Mark. I think as I suspected early on in the conversation, we will run out of time given how interesting this topic is. But I would like to thank all 3 of you and for weighing in on that question. And I think I want to thank Chelsea and Addison for monitoring the chat for the questions. And it looks like we may have a few questions that were not answered. So my email is in the chat box. So please feel free to send me your questions. We will have a transcript of the chat. So if I find questions that were not answered, I'm happy to reach out to you as well. And then I want to leave a comment that was left by one of the participants was that we talked a lot about stigma in the marginalized populations that we talked about, and it was pointed out, and that's again a learning that I am trying to gradually be more mindful of, is how we use the label smoker, and then that we don't anymore refer to people who are addicted to substances as addicts. So maybe we should maybe be more mindful to use the terminology people who smoke or person who smokes than smokers. And I think that's a great point, and that's a learning for myself as well. So with that, I'd like to say that this was such a great discussion. I learned so much, and I hope our audience felt the same way. We are, so to say, at or approaching the last mile of eliminating smoking, but we are also at the most challenging mile, where we are working with the least able or the least willing to quit smoking subgroups. So to sum up today's conversations, the key takeaways for me were that prohibition has not worked, will not work. Consumers need diverse, well-regulated options and acceptance to transition to a safer choice. And one-size-fits-all approaches tend to leave out the most marginalized communities. So thank you so much to Kevin, to Patricia, and Mark for sharing such rich insights, for adding such diversity to the information and with your backgrounds. Outside of academic public health and tobacco control and advocacy organizations, we don't really hear a lot from other stakeholders like we talked about. So I'm thankful to all three of you for sharing your perspectives. I hope this is one of many other conversations to follow. So once again, thank you all for joining us.
Thank you.
Thank you.
Thank you.